So good afternoon, everybody. At the outset, let me thank the organizers for giving me this opportunity. And as you have seen, they are very strict about the time. So I think we should be able to finish in 30 minutes. So as we all know that a disclaimer first that I'm a medical oncologist. So I have the last role in the management of endometrial malignancies. And myself and Nilesh, we will be the person who will be coming in last, because invariably these are the patients who present early with an early disease, and invariably good job is done by the surgeons. A big role of a pathologist in the management of endometrial malignancy, and we have Dr. Srividya for that, and also a role of local therapy in the form of either brachytherapy or external beam radiotherapy by our radiation oncologist. Okay. So here we go. We have a patient who presented. As I said, I'm a medical oncologist. So in 2019, I had not seen this patient. So this patient came to me later. But anyway, this is a short history. 70-year-old female, diabetic, hypertensive, presented with a postmenopausal bleed for 2 months. Dr. Prashant, anything else you would like to have in history? Maybe a family history?
Hello. Any clinical examination details?
So, clinical examination is something which is very important. Like I said, I'm a medical oncologist, so I'm asking you what you would be doing further.
So definitely 70 years old female, I would like to have a clinical examination of the patient, a per speculum examination and a per vaginal examination. Know her fitness, because next things are surgical. So I would like to see the fitness levels. That is important.
And you will investigate her for, because it's a postmenopausal bleed, you would like to know whether she is suffering from an endometrial malignancy.
Definitely.
No, it can be cervical cancer also, endometrial also.
Correct. Correct.
So that's right to differentiate. A simple clinical examination can tell you whether it is cervical. If you don't find any lesion in cervix, then a USG or MRI it will help.
Absolutely. So this is an ultrasound report of this patient, and the endometrial thickness is 21 millimeters. So is that good enough for us to go for a biopsy suspecting endometrial malignancy, or is there any cutoff area for endometrial thickness where you suspect it may be malignancy, it may not be malignancy, in a patient who is having a postmenopausal bleed and a patient who is not having a postmenopausal bleed?
So definitely 21 is good enough. In cases of postmenopausal patients, 4 mm is considered as cutoff.
That's right. So 4 mm for a patient with low risk, and if there is a high risk, anything you would still like to go for a biopsy irrespective of the thickness. And what about if they don't have a bleeding? So it said that around 11 millimeters, anything above 11 millimeters, you would like to do a biopsy irrespective of the patient presenting with a postmenopausal bleeding. So just an idea about what we do with the patients who present to us in a postmenopausal bleeding or without a bleed.
We'll also check for some medication history in case if she is on some hormonal or supportive, because you said 11 millimeter without any bleeding. So definitely sometimes they might have some just edematous endometrium.
So she was investigated, and this is the report we have. A word from Dr. Srividya. Madam, do you think, because I am practicing in a tier 2 city, and I always see grade 2 as the histopath report. So is it a defensive medicine that you don't want to comment on grade 1 or grade 3? Because everything changes for me for managing an endometrial CA. If it is a grade 3, the risk factor stratification will definitely change as compared to grade 1 or grade 2. Or just that it is common, that grade 2 is more common as compared to grade 1 and grade 3.
The current FIGO grading that we use, that's based on the percentage of a solid non-squamous component. And there are 2 magic cutoffs. One is 5%, the other is 50%. Anything 5 or less than 5 is grade 1, greater than 50 is grade 3, and the rest is grade 2. So whenever there are such numerical cutoffs, there is a lot of subjectivity, but we face this between grade 1 and grade 2. grade 3 is usually easy to tell on morphology. So having said that, I think between grade 1 and grade 2, I think there are a lot of voices in the pathology community which are asking for a two-tier grading, a low grade or a high grade. And I think that will soon come. So grade 1 versus grade 2, yes, it's subjective, but grade 3 is usually easy to tell, in which case we have to consider the other non-endometrioid carcinomas also. We have to rule out serous, clear cell. That's a combination of morphology and immunohistochemistry.
Great. So this patient underwent a CT chest, abdomen, and an MRI. As a surgeon, I would like to ask Dr. Prashant, is that good enough for you to go in for surgery, or you would still go for a PET CT as well?
Normally in the low grade, I would like to go for just a CT and a MRI is sufficient. Again, as we all come, there are cost constraints. Sometimes if it is a low grade, then a sonography is also sufficient for us. A good sonography including the upper abdomen, knowing that there is nothing major in the upper abdomen. If affordable, then MRI and the upper abdominal CT is the best. PET scans I normally keep reserved for only two cases. Either it is a high grade or non-endometrial pathology. Third thing, if I am planning for robotic surgery.
So suppose I say that you do an ultrasound that's good enough and it's stage 1, but it can happen that on MRI you might have it as like what this patient has a cervical stromal involvement, so it becomes a stage 2 disease. Then going in for an open versus laparoscopic versus robotic, it might be a choice which you might lose just on an ultrasound. Is that okay, or would you still like to think on that?
Even if it is a cervical stromal involvement, currently the standards are you do a simple hysterectomy, you don't go for a radical hysterectomies.
The issue comes, that you do a surgery and then the pathologist reports that there is a substantial lymphovascular invasion, and then the problem starts.
That's why I told it is a good sonologist. You have to have a very good sonologist who is able to, in cases where the cost is constrained. Otherwise, MRI is the best tool.
Okay. So, I mean, as of now, we know that this patient is a stage 2 disease because a cervical stroma is involved in an MRI, and patient is having an endometrioid type of endometrial cancer, grade 2. So, this is a poll question. What type of surgery? Is it open, laparoscopy, or robot? Okay. So interesting poll. I mean, seems less people are having a robot in their hospital as of now, because having a robot is an indication for surgery. So this is a study of comparison of recurrence of using a robotic versus laparotomy, and there were high recurrence rate on using a robot. Similarly, for stage 1, you have the long-term survival is not good. I mean, if you look at the lab 2 study, after which everybody started using laparoscopy or a minimal invasive for endometrial malignancy, it was done for stage 1 only, and it was basically a safety and morbidity which was compared and not a long-term survival. So as per the recommendations, minimally invasive surgery is the recommendation in stage 1, grade 1, grade 2, endometrioid type, and sometimes in stage 1, grade 3. So actually this patient to begin with had a stage 2 disease. What about lymphadenectomy? Dr. Prashant?
Sorry?
Lymphadenectomy.
So in grade 2, what was the size of the tumor?
It was an endometrial thickness,
Thickness.
21 millimeters, and there was involvement of the stroma.
Cervical stroma. So standard I would go for a pelvic lymph node dissection and para-aortic lymph node if the pelvic nodes are bulky. If you have a frozen section, definitely on the pelvic nodes that will help us.
Sentinel node you want to comment
Sentinel
on?
node is the best thing available. If it is there, ICG dye or previously methylene blue dye, but it depends on the place to place availability. So sentinel dye is the best thing available.
And in case this is a serous or a carcinosarcoma, will your surgery change?
In carcinosarcoma, in anything other than the endometrioid, I would like to go for a proper pelvic para-aortic lymph node dissection and a omentectomy. If anything other than the endometrioid.
So in serous and carcinosarcoma, I think omentectomy should be done like you operate for an ovarian malignancy. So extended surgery is the option. So this patient underwent a robotic radical hysterectomy, starting with a stage 2 disease. Now it is a stage 3 disease, grade 2 endometrial malignancy, endometrioid type of endometrial cancer, more than 50% involvement of the myometrium. Left pelvic lymph nodes were positive, no lymphovascular invasion or perineural invasion. So it's a stage 3 disease. Dr. Srividya, anything else you want to add to this histology?
I don't see the invasion of cervical stroma mentioned here, but other than that, I think it's fine.
Any comments on substantial lymphovascular invasion,
Yes,
focal lymphovascular invasion?
Yeah, lymphovascular invasion is now graded into 3 grades, no, focal and substantial. And substantial meaning there should be 4 or more lymphovascular spaces at the advancing edge of the tumor, which shows tumor emboli. Well, this is easier said than done because there are a lot of artifacts which can interfere with our interpretation, especially in laparoscopic surgeries. So that is how it works. And diffuse lymphovascular invasion, important to document it because of the risk of regional recurrence.
So there is always a problem, if Dr. Prashant is operating, we know that he will be doing a good job. But it so happens that 80% of the patients are operated by gynecologists. I'm not saying that they don't do a good job, most of them are doing a good job, but this patient comes with a stage 2 instead of stage 3 and has a substantial lymphovascular emboli, and patient lands up with Pramod. And would you go in for a restaging of these patients, or you would start them on external beam rate because it's stage 2, so I think vaginal may not be an option. Go for an external beam or add chemotherapy, or anyway you upstage it because there's a lymphovascular embolism.
See, it is very clear-cut case. You are saying LVI is positive, cervical stromal invasion is there. So, and if it is operated by gynecologist, I need to see how many lymph nodes were dissected, whether the surgery was complete or not.
So lymph node we don't have. We don't have a lymph nodes. It is just a total abdominal hysterectomy with bilateral salpingo-oophorectomy.
Yeah, so if it is grade 1 or 2, I'll just get an imaging done to look for nodes. If it is grade 3, definitely we need to do restaging surgery.
Yeah, but sometimes, it is not easy to really convince the patient to go in for surgery immediately again. I mean, that's a practical problem. I understand.
It's difficult, but yeah, if it's grade 1 or 2 with few risk factors, then the chances of lymph node involvement are less. So, repeat surgery just for lymph node dissection may not be necessary, but for non-endometrioid histologies and grade 3 endometrioid, the chances of lymph node involvement are more. So that's why it is important to surgically stage the patient.
Nilesh, going ahead, I mean, have you started asking for the molecular subtypes also along with the estrogen, progesterone and HER2 status to start with, like this patient once it comes on a post-operative, I mean, it does happen that sometimes this patient come to us also with this histopath post-operative, what is to be done. So does having molecular subtypes to start with help in management or planning the line of treatment for these patients?
So based on the TCGA classification, now we have 5 subtypes of endometrial cancer. So you have the ultra mutated or the pole mutation positive, then you have the hyper mutated or the MSI positive, then you have the high copy number which is P53 positive, the low copy number which is neither P53 nor MSI high, and then you have the mix and match which is the 5th category. As of now, we don't do pole for sure, but P53, MSI HER2, and ER and PR. These are 5 that we are routinely doing. In the adjuvant setting, there is an important role of pole mutations in de-escalating for patients who have a pole mutation. You can de-escalate the adjuvant strategies, but I have not been doing it, and in fact, I'm not very sure if it's very easily available. It probably is available in a NGS platform, so we have exon 9, 11, 13, and 14, which can be mutated, but I'm not routinely doing it.
At the same time, if you have TP53, maybe you will escalate your treatment.
Correct. So a P53, an MSH-S, a PMS2, as well as an MSI. These are the 4 things that probably would be relevant today.
Will that also help you in adding immunos in the adjuvant setting?
Not in adjuvant.
Okay. So this patient had a stage 3 C1 disease, and as per the risk stratification, stage 3 endometrioid with no residual disease comes to a high risk patient, and we need to plan the adjuvant treatment for this. Can I have the poll? So that's what CTRT followed by chemotherapy. Dr. Pramod, is this what you refer to when you are planning an adjuvant treatment?
Yeah.
So all the points are covered, and you, depending on these points, you decide what adjuvant treatment the patient should undergo, right?
Yes.
Okay. So what will be your plan for this patient?
Yeah, before POTEC 3 trial, we were considering all these patients only for adjuvant radiotherapy, but after POTEC 3 trial, we have started adding chemotherapy also in concurrent setting also, and after CTRT, 4 cycles of adjuvant chemotherapy.
So when I started my practice for other than ovarian malignancies, in gynec cancers, there was no other treatment available, no chemotherapy. Slowly, I think medical oncologists are coming in, chipping in for adjuvant also. Metastatic, we are always there, but for adjuvant also. And paclitaxel and carboplatin. Very Chetan? Chetan wanted to touch the feet of a person who has designed this paclitaxel carboplatin regimen. You know, because if you see, jahan kuch nahi hai, wahan pe paclitaxel carboplatin. I think for so many tumors, we have this option of paclitaxel carboplatin. This is really a wonderful regimen, very easy to be given, and invariably we have seen in so many malignancy it works. So, POTEC 3, so your comment on this POTEC 3, I mean, if you see this trial, it's usually a stage 3 patients and stage 4A patient where there is a maximum benefit as compared to stage 1 and stage 2. Though we put them as a high risk right from stage 1, B grade 3 onwards, but the main advantage has been seen in stage 3 patients. Also, if you see, most of the advantage also was seen in serous type of endometrial malignancies. And there is a translation analysis of this study, and you can see that the pole positive patients are doing very well. So maybe like what Nilesh said, can we de-escalate the treatment? Okay, and I think P53 mutations, definitely we should go for this because there is a definite benefit in that. I need to rush through few of the slides. Another important study in this is GOG 258. If you see, the CTRT arm is the same, what is there in POTEC, but it's compared with chemotherapy alone versus radiotherapy alone. Though the arm, CTRT arm is the same, the PFS is different in both the studies. I don't know why this is. So in POTEC 3, the PFS at 5 years was 71% as compared to 60%. So this is what we have discussed. So depending on the molecular subtypes, the further studies are ongoing, and probably there might be a role of immunotherapy as well in the adjuvant setting. So this lady was planned for 6 cycles of chemotherapy followed by external beam and brachy. But the usual issues, kids were staying abroad, they had only a few time in this country, so they went ahead with radiotherapy, followed by brachytherapy and weekly carboplatin. And this is the first time I have seen this patient last month, complaining of lump in the lower abdomen for 3 months, abdomen pain for 10 days. There is a mass and biopsy is showing a recurrence of endo. This is the lesion, what is seen. Dr. Prashant, do you feel that this is a port recurrence which was operated by a robotic surgery in 2019? Because there is no local recurrence, no pelvic recurrence. This is mainly a recurrence which is coming on the skin or maybe in the abdominal wall. So do you think this is a port recurrence?
In robotics, normally we don't morcellate or we don't do anything. So normally vaginally.
I am a medical oncologist. I am just taking your opinion.
So vaginally we take it out, or laparoscopic people put it in a endo bag and take it. So unless there is a skin site, I wouldn't like skin site involved the port site.
So do you think this patient can be operated in future or now?
It is just 3 months post radiation.
No. Radiation was given 2019.
19.
This is 2022.
Right. Any other nothing, no site of
No,
any other.
nothing. There is nothing else.
Yes, definitely. I would like to go for surgical excision.
Okay. So let's have our last poll question. Surgery followed by chemotherapy. Chemotherapy first followed by surgery. Palliative treatment only, and whether you can re-radiate these patients. This patient. Okay, 50-50.
Divided.
So we decided to put this patient on chemotherapy, and just to put few trials about chemotherapy, triplet chemotherapy versus doublet chemotherapy. Doublet chemotherapy is as good as triplet chemotherapy, GOG 209. You can see both the curves are superimposed on each other. Is there any role of anti-angiogenic therapy? Nilesh, can you just chip in?
So, paclitaxel and carboplatin remains the cornerstone of therapy in this regimen, in this disease. Combinations with bevacizumab or with adriamycin can be done on a per-to-per case-selected basis, but definitely not for everybody. And there is no role of maintenance bevacizumab in this disease.
So this is the data of bevacizumab in endometrial malignancies, GOG 86P. But if you look at the 3 arms, there is no arm of paclitaxel carboplatin. In fact, what they have done, if you read this, is they have picked up that arm from GOG 209 and compared it. So it's a cross-trial comparison of bevacizumab versus paclicarb. However, I think in clinical practice, most of us must be using this, because I don't see so many endometrial malignancies. But I mean, like in gynecological cancers, bevacizumab has a role. You can also see the graphs going apart in TP53 mutated patients with the use of bevacizumab. Nilesh, again your take on HER2 positive patients, and where do you advise HER2 testing in these patients?
I would advise a HER2 testing in every patient, especially in somebody who is a grade 3. But you see it in about 15-20% of patients, and if it is positive, these patients do benefit from an anti-HER2 strategy in combination with chemotherapy.
So do you advise only in serous patients or carcinosarcomas, or even in endometrioid as well?
I also do it in endometrioid, but not in carcinosarcomas.
Okay. Dr. Srividya, do you follow the same algorithm for HER2 diagnosis as breast cancers? Because I don't know of any testing platform or something like that for an endometrial malignancy. So you follow what you see in breast cancers?
More or less, yes. The same percentages are used in endo.
I think your mic is off.
Yeah, it is the same.
Yeah. There's no specific this for for endometrial cancers.
Unlike gastric cancer. No.
Okay. So there is a role of HER2 directed therapy in advanced metastatic HER2 positive endometrial malignancies. Any role of hormone therapy in metastatic, advanced metastatic endometrial malignancies, suppose they are ER positive?
So, of late we've been just talking about targeted therapy and immunotherapy, but we must not forget that this is a disease that is very sensitive to hormonal manipulation, and that is even in patients who are ERPR negative. So, in low-grade tumors, in an elderly patient, it would probably be my first choice of treatment. Either a sequential use of medroxyprogesterone with tamoxifen, or even a single agent aromatase inhibitor, or an AI combination with everolimus. These three are options that can be used.
So, of these options, which is your first option?
Medroxy.
So, progestins is something which you would like
Yes.
to go for first.
Yes.
Your comment on this study?
I'm sorry?
Comment on this study? Palbociclib plus letrozole versus only letrozole.
I'm not aware of this study.
Okay,
I'm not able to in fact see the slide.
Like in breast cancer, CDK4/6 plus an AI was used, and actually there is a good data. I mean, this particular study shows a good disease control rate, and a PFS was significant in palbociclib plus anastrozole or an AI arm. The only thing is, I think that probably the comparator arm was weak, so maybe that is the reason that we have. But this is an option available using a CDK4/6 inhibitor in an endometrial malignancy. Toxicity profile, I think we all know, nothing specific. As we know about CDK4/6 palbociclib, the toxicity is as per the breast cancer studies. What about immunotherapy, Nilesh?
So, in the first line treatment, if the MSI is high, then a single agent pembrolizumab is an option of treatment. Apart from that, in the first line, I think IO would not be something that is a standard of care as of today.
So, in a biomarker driven situation, you would like to go for an IO in case you don't have an option of after your recurrence and paclitaxel carboplatin, you don't have an option, you would like to go for an IO if it is MSI high.
In the first line setting?
Second line.
So in the second line setting, I would consider an IO with lenvatinib irrespective of the MSI status, and we have evidence that it works well in both these subgroup of patients.
Okay.
A small subgroup of patients who have the NT-RK fusion genes are can also benefit from targeted therapies like entrectinib, but that's a very small proportion of patients. You said biomarker, and that's why I'm mentioning that.
So, you'd like to go for NGS at this situation and try whatever is possible?
Beyond the second line, yes, why not?
Okay. So, this is a second line option for advanced metastatic endometrial malignancy, comparing the physician's choice, which actually is not much option available in the second line, doxorubicin and paclitaxel. They have already progressed on paclicarb. Giving a paclitaxel again every weekly is an alternative option compared to pembro and a TKI, lenvatinib. So for all comers, there was a good progression-free survival and an overall survival. I think this data is out in last, I think, couple of months or 3 months back in an NEGM. So this is another option we have in a second line patients who have progressed on paclitaxel carboplatin, where you don't have much options available. So before they shut my mic, let me summarize what, yes, Devanshu, I am doing it. So to summarize, I think the most important thing is how we start once we have a patient of endometrial malignancy. And the most important work is done by the surgeons and the pathologists. I think they are the ones who give us an exact risk stratification and the stage of the disease. And once we have that, we can keep the book in front of us and plan what we have to do. Molecular classification is coming in the near future. We discussed about pole mutation and P53 mutations and what is the role in treatment. Chemotherapy along with RT, we discussed GOG 258 and the PROTECT-3 study. And then comes palliative treatment with chemotherapy, with hormone therapy, and probably immunotherapy is now coming up in metastatic C endometrium. With that, I thank the organizers and the panelists and the chairpersons for attending this session. Thank you so much.
Thank you.